Thank you, Victor, and thank you all. I'm flattered that I would be asked to be here, and embarrassed because I'm not coming to you as an expert in the least. I begin the book by talking about how little I knew about this field. And I begin by saying that I learned about a lot of things in medical school, but mortality wasn't one of them. Senator Collins was absolutely right. It was less than a day that when I completed medical school, that I had on the subject of the unfixable problems that people have. And, you know, when you go into medicine, you're going into medicine because it's the chance to fix. And I think also for our professors, it's what are the diseases people have, how does the body go wrong, and what can we do about it? And we don't think of ourselves as people who have to think about the problems that you cannot fix. I became a surgeon, which is fundamentally about the idea of walking into an operating room and walking out and you've made people better. That is what you went there for. But then when I got into practice, I found that a significant amount of my time was spent taking care of people who had unfixable problems. They had chronic illnesses, they had frailty and disabilities that were getting worse, and then they had terminal illness. And while I felt incredibly competent when I had a solution to offer that would make people better, that would take care of their disease, that would prolong life, I felt incredibly incompetent in situations where I couldn't do that. And so, as part of trying to think through these problems, and then finding it had taken hold in my own family, with my father, a surgeon himself, being diagnosed with a brain tumor, a brain cancer in his brainstem and spinal cord. As part of that, I spent what became 5 years investigating this issue. And where I came to was really the same place, almost at the same time the Dying in America report came out. And I'll tell you what I took away, but they're mirrored. They're much the same. And I think what we are ending up doing is doing what Mark Warner had talked about, which is the idea of trying to make it safe to think about and talk about and struggle through how to make these issues better. The problem we're facing is one that's a consequence of good news. We have added, in the 20th century, 30 years to people's lives. 30 years. Much of that before 1960 from the benefits of public health, improvement of survival in childbirth and in early childhood illness. And since 1960, we have added, through medical care and nutrition in a variety of fields, we've added 5 years of life for people who reach the age of 65 so that they live on average 2 decades. Live on average another 15 years when you reach the age of 73. Now, there's a dramatic consequence that has occurred in what that phase of life begins to look like. In 1945, most people died in their homes. And the reason they died in their homes is that medicine really didn't have much to offer. They didn't see a reason to go to the hospital, and it was understandable. But we've had now a half century of incredible discovery where we can address many diseases and illnesses. We can offer treatments. And so by 1990, 83% die in institutions at the end of life. And that remaining 17% would likely have ended up in those institutions if they hadn't died so suddenly or weren't so isolated in their lives. And so what we've experienced is the medicalization of mortality, where we've begun to treat it as a problem requiring treatment just like any other condition that happens in the human experience. It's become a process that's been incorporated into our focus on our treatment, focusing on stopping disease. But what do we do when it can't be stopped? What does it mean as a consequence? I think we're now seeing as the baby boomers experience their parents go through this, and they're witnessing it for themselves. What we're seeing is a tremendous cost in dollars, but far more, and in far more devastating ways, in suffering. What's the most likely week you will have surgery in your life? The last week of your life. And that's the week that you know surgery is not going to do a lot of good for you. You have all of the pain of that experience, all of the complications, and little time to have gotten the benefit. Between 1988 and 2010, the experience of people at the end of life is that they have more pain, more depression, more difficulties with confusion. They are all increased at the end of life without evident benefit. And so what we've seen is a 50-year experiment with medicalizing mortality by focusing on disease-focused treatment. And my conclusion after looking at all this is that that experiment has failed. Failed because it's increased suffering without increasing any of the things we care for. Longer life, better quality of life. But then what do we do? Well, what I found every day in my clinic was I didn't know the answer to that. The people I would see would come with frailties, with terminal illness, and the questions that we would come to would be, should we do something? Should we do anything? Something to have the possibility of more time, or should we give up? And it felt like those were not the only options there had to be, but I didn't know how to even think about it. It just didn't seem like a choice. Well, of course you're going to do something. Why wouldn't you do something rather than nothing? Well, my investigations along the way ended up finding that a good answer was tied to some seemingly unrelated work. A Stanford professor, Filippizo here, named Laura Carstensen did a landmark series of studies tracking and studying the emotional lives of people as they aged. So, for example, she took people ages 18 to 94 and has been now following them for 20 years, more than 20 years. They had beepers that they would carry around, and the team they agreed to carry these beepers, and the team would page them, and at that moment they would be asked to record, what are you experiencing? Are you happy? Are you sad? Are you angry? Are you frustrated? Or the questions they would get posed like, okay, if you had 30 minutes right now, who would you rather spend it with? And you'd have a range of options like, I'd like to be with my sister, or, you know, I'd love to meet the singer of my favorite song. Would you rather see your sister or the singer of a favorite song? You know, so as you go through this, and they started to then have some incredible results, what they found was that there was a dramatic change in the experiences. Our desires change. When we're younger, we believe what we want is achievement and recognition. We're getting, having, accumulating, acquiring. We want larger networks. We don't want to spend our time with our sister. Like to meet that singer. You know, we don't want to go out with our mother. We want to go to a nightclub where we're shouting at the top of our lungs, plastered against the walls at 2 a.m., hoping you might meet somebody new. You change, it turns out. And the changes are really interesting. One of the things that happens is that people's desires, not only desires change, their actually emotions change. First of all, they can experience different emotions at older age than you experience when you're young. For example, you can experience poignancy, which is having a negative and a positive emotion at the same time. That bittersweet feeling, which when you're younger, you don't actually experience. Also, what's striking is that as she was following people along as they aged, their health declined, their abilities declined, and their levels of happiness increased. Levels of depression and anxiety, people over 70, are markedly lower than in people under the age of 50. This is contrary to the way that we think. We think being aged is miserable, and that surely if your health is getting worse or your abilities are getting worse, then you must be more unhappy. The one group as you get older who become unhappier are the group who become institutionalized. People who are in hospitals and in nursing homes. And it's worth thinking about and understanding this. One of the ways that I tried to understand this was to puzzle over, well, if this happens as we age, why does it take so long to get what we would call wisdom? Right? People become less focused on acquiring and having and become more focused on a smaller group of people and wanting intimate, deeper relationships, being connected to the people you care about, wanting to make sure you're making a difference for them and not necessarily needing the kind of recognition and acquisition that you have when you're younger. So why does it take so long? And the theories were that maybe our brain changes as we get older. But then Laura Carstensen found there was a group of people when she started the study who were young and became terminally ill. Being studied in Northern California and it was still in the early period of the HIV epidemic. And there weren't as good treatments as we have now. And so there was a group of people who became terminally ill, and what she noticed was that group looked like the older population. They were not trying to acquire and have. They were focused suddenly on a narrower group of people. They were wanting to spend time and simply be with people that mattered to them, that their hopes and goals shifted. And then, as the study went on, they experienced 9/11. And during 9/11, what she saw was the entire population shifted in the direction that the older signature had, which is young people didn't suddenly want to be in the nightclub. They actually wanted to see their sister, wanted to hang out with their mother. And what that told us was some really fundamentally important things. One lesson was that well-being is possible even under severe constraints, under difficulties of health, difficulties of terminal illness, difficulties of disability. And we've lost sight of that. And second, that people also change in ways that one generation may not understand happens to another generation, or people who are not facing serious illness may not understand about what happens when they start to face serious illness. The people's desires, goals, what they want changes. Well, there's been a dramatic change in the last century, and it's not just that we're living longer, the trajectory of life has changed. Before, in the 19th century, there was no clear relationship between getting older and your risk of dying. You could die at any age, 5, 20, 40, in childbirth, in horse and buggy accident. And so aging was just something where you were lucky enough to make it to that older age. And the result was that uncertainty and fragility in life was always with you. And so people thought about these kinds of concerns. Today we live mostly as if we're immortal. You really don't have to think about it. Even at 65. You don't have to think about it unless you suddenly get one of these conditions or illnesses. And then gradually you do have to think about it, and your view of the world changes. Well, one of the consequences is that, therefore, in our society, and in many societies that have these advancing healthcare systems, we come to see a good life as being one of independence and health, and that is what a good life is. We don't have a picture of a good life that fits with a view where you are aging to the point of becoming frail, or in a world where you have sickness. So the result is that our medical focus has been on one where, we don't say to ourselves, you know what, I really hope I can flog my patients at the end of their life. What we say is our priority is health and stopping disease. And why wouldn't it be health and stopping disease? But the result is that we are actually lost. We are lost if health and stopping disease is not possible. We're lost about what it is that we should be doing. What we have lost sight of is that well-being for people is bigger than just health and survival. Of course, being healthy and of course surviving matter to us, but it is not all that matter to us. And therefore, what we experience as we are aging, and we live in a world where the people we depend on, when we become frail enough to need help, whether medically or from aging care, the result is we have suffering because we are working with people who do not understand what we need. So in old age homes, you see that out of a need to keep you safe and healthy, you can't have a drink. Kind of choice you could make in your own home. I was at an IOM meeting, and a White House staffer came up to me and said that her mother has Alzheimer's disease. As she was in her dying phase, she had to sneak bananas in because she had a medically ordered pureed diet. And all she wanted was some solid food, and it was not allowed. She would smuggle bananas in and feed the killer bananas to her. And there's nobody at the same time asking about what might really matter to them. Their ties to their friends are cut off, ties to a church or synagogue that they belong to, that they want to stay connected to, are removed. And it's not about costs, simply about whether those priorities become ones that are recognized and understood. And you see it in hospitals too, where the idea is that it's an either-or proposition. Do you want a longer life, or do you want a quality of life? And this idea that, do you want everything done, or do you want just comfort care, is a false and dangerous dichotomy. It speaks of an imagination, a poverty of imagination. It is a lack of imagination that life worth living is still possible. And it is. I interviewed in the course of the book about 200 plus patients, family members, about their experiences with debility, with aging, and with terminal illness. I interviewed scores of palliative care experts, frontline nursing home workers, hospice teams, academic experts, contrarians, reformers, radicals. And the key insights that I felt like they had was that we failed to recognize that people have goals and priorities in their lives that they need us to serve besides just living longer. Their goal, for example, as they near the end of life, is not a good death. Their goal is as good a life as possible at every phase of their lives, including the final phases of a person's life. And that's what we've not thought about. What does a good life mean? What are the goals and priorities for a good life for you, where you are with your illness? That is not, do you want quality of life or do you want survival? The way you learn what people's priorities are is a highly technical process. You ask them. And we do not ask. Less than a third of the time does a clinician have a discussion with a patient about what their goals and priorities are for their health worsening before the time of their death. That group who has that conversation has far better outcomes. They have less suffering. They spend fewer days in the hospital. They're less likely to die in an ICU. They live longer. They live longer. The core things that I learned was then how do you make it possible? And it starts with a few basic questions that people who are in palliative care who think about how to make goal-centered care instead of just purely disease-focused care, but they ask, what is your understanding of where you are with your illness? What are your fears and worries for the future? What are your hopes and goals if time becomes short? What are you willing to sacrifice for the sake of possible more time? And what are you not willing to sacrifice? Does your family know the answers to these questions? When they ask, in multiple studies now documented in this Dying in America report, when people have earlier conversations about their priorities for living with serious illness, they receive care that results in less pain, less anxiety, less family exhaustion, better patient and family coping. They end up with less non-beneficial care, results in less hospitalization. That means lower costs at the end of life, and it means people actually live longer than compared with purely disease-focused care. That is the radical idea contained in the Dying in America report. That is the radical idea that feels unsafe for people to talk about. And it's the radical idea that we need a structure at every level to support and make possible, and that we're not doing. I've seen it myself when I take care of my patients, and I saw it with my father. As his cancer advanced, we had that conversation. One of my colleagues, a palliative care physician, told me about having it with her father, who had a tumor similar to my dad's. And as my father was progressing to quadriplegia, she talked about how her father, when he was facing the same situation, she asked him, what are fears and goals, what matters to you? And he said, you know what? As long as I can eat chocolate ice cream and watch football on television, I'm good. But take that away and it's not worth living. So I said to my dad, he said, chocolate ice cream and football on television, what matters to you? He said, that is not good enough for me. For him, it was a dinner that he would have almost every week with his friends and family, where he could be at the table and talk to people and interact. If he could still do that, even just once a week, it's going to be good enough for him. It was the best living will ever. We use that to guide our care at every step of the way. Will my dad still be able to come home and sit at the table and have dinner and talk with people? The answer was yes, as he became increasingly quadriplegic, for going for a radical operation that bought him more time at that table. It was maybe with a radiation therapy, and we went for it. Didn't work, and it cost him time at that table. Then with chemotherapy, we got an oncologist who said, here's your options, 8 different options, 3 doctors in the room, my mother, my father, and me, and we still had trouble making sense of it all. Trying to ask, well, how much time does he have? Just what's the range? It's hard for them. They didn't want to give that answer. They didn't want to tell you which one would be the best way that you could sit at that table. We had to kind of figure it out for ourselves. And ultimately what he figured out is he did not want that chemotherapy. He started on a simple steroid treatment, and it wiped him out. And that was when, in rural Ohio, ended up with a hospice nurse from Appalachian Hospice Services. Most amazing thing. He went from being completely disabled, unable to walk, looking like it just had a couple weeks left, to having 4 months because they worked to strengthen him, figure out how he could stop having falls, get his pain under control, and he came alive. He was a person and not a patient for the last 4 months of his life. And it was the biggest, most important gift we could have gotten. And it was a fraction of the cost it would have been going down that other path. How do we make this happen? How do we go forward? I think the other thing that this report does, which my book didn't do. Let's talk about how that it could be. It's very clear shifting from fee-for-service care to fee-for-value is part of how we do that. And I know many of you from the groups here are engaged in pushing that agenda forward, and it's really important. It's an amazing thing that between 2011 and 2014, we've gone from 0% of Medicare patients who have doctors who are being paid something other than quality, than being paid for the quantity of care they provide, rather than for the value and quality of care they provide. We've reached 20%, and a target of getting to 30% by next year, by the end of 2016, I think is a fundamental goal we need to deliver on. I think that we need to be able to know, we need to monitor in nursing homes, medical care, and hospice care. Do the people taking care of you know your priorities, and do they respect them? We can't answer that. We're improving the likelihood that that's happening. We're not succeeding. We need to include it in the measures of whether we're making accountable care, Medicare Advantage, and other programs successful. We need to include these kind of measures because right now they don't. As we look at across the board, as we're integrating care, we're leaving this part off of the agenda, and I think that there's a valuable, important appendix David Stevenson and Hayden Huskamp have written towards the end of the report that outlines some of the financial policy barriers to these things happening. For example, Medicare Advantage does not include hospice care, so people are not connected into integrating it into the services in the same way. And we have to support the research and innovation that makes this possible. This is a tsunami every one of us are experiencing in our families. It's a dramatic change in the experience of living, and we have virtually no innovation and research support for transforming to ensure we move from disease-focused care to goal-centered care, the goals of the people that we're to take care of. In medicine, we have to teach the skills we didn't have. We have to recognize who are the sickest. The most important thing I learned, for example, was the question to ask yourself is, would you be surprised if this person would die in the next year? If the answer is you wouldn't be surprised, number one, doctors are very good at answering that question. It predicts a group of people who are at serious risk for their life. And second, that's a group of people who need this conversation about what their goals are. We have to understand that not having a conversation about the priorities that people have, especially that group of people who are the most seriously ill, is a failure. A failure that causes genuine harm. We have to understand that. In politics, part of my inclination has been keep the politicians away from this one. We need the space to be able to solve and move this forward. But I am encouraged that more and more I'm hearing the exact dialogue we heard here. When I launched the book tour for the book, I decided to do it in Wichita, Kansas, which was home of a medical society and a political legislature that were very uncomfortable with putting this on the agenda. And when we launched the book and I was there, what you heard from the legislators there and from the medical community as well as the local community was about their mom, about their dad, and what they saw happening and how it cannot continue. It cannot continue. That's where we know that even the political barriers, I think, are down and can come down. Finally, there's a cultural movement, and that's an important part of what we have to do. We can demand life worth living in all phases of our life. We have to recognize our objective. It's well-being in all phases of our life and not just stopping disease. The results will be a far better life all the way to the very end. Thank you.